Hello, 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 hello. Good afternoon, students. Let us start. This is the important topic we are trying to cover. The classes from MUHS have been conducted in past also. We are restarting on your request, and we have divided classes in three groups. First group is the syllabus. We have gone through your syllabus, what have been asked frequently. We have tried to do that. And second group is the classes which you have asked for it. And we have taken those classes such as JVP, recording of blood pressure. Many of the classes you had asked for it, and we have responded to your request. The third groups of classes are the practical classes we plan to organize for you very soon, and it will be in batches, and we will accommodate as many as possible with our setting. It will be hands-on, and it will be workshop model in which you will join us in the morning. You remain with us whole day, and then after end of the class, you go home, which will comprise of 8 to 9 hours training. And we will show you different patient, how to examine them. And then after you divide into the batches in which the specific tutors will be teaching you about their skills. It is important to make a disclaimer, and we hereby make it. These classes are done for the benefit of the students to facilitate preparation for exam and practice. It does not give any right, interest, or claim for registration, continuation, or certification by MUHS or any of the affiliated institution. We come to very important aspect, diabetes. It is asked every year, and then after you have to understand how to go about it. We will divide this class in two parts, that is the epidemiology, classification, diagnosis. We will concentrate here. Treatment part, we will concentrate, and complication in next class. Very soon. Hello. अच्छा बाद में बात करना क्लास में. Okay. We are at the definition. It is very simple to understand. That is, diabetes is a hyperglycemic state resulting from decreased insulin secretion, decreased insulin action, or both. Why it occurs, we will come to that. And you will find in older books the class definition written as hyperglycemia, that is hyperphagia, polyphagia, polydipsia, polyuria, loss of weight associated with hyperglycemia. So these all are there. Many of the newer books, they talk about the hyperglycemia, and which can be due to reduced insulin secretion, or insulin action, or even both. Why it occurs? There is the lot many pathophysiological processes involved, and these have to be identified because treatment for the different groups are different. That is why it is important to identify the types of diabetes. Worldwide, the disease is increasing, and then what you are noting, it is the top disease which is causing the mankind to a very large extent. And what is they have worldwide projected, WHO, 300 million people by 2025. That is the 5.4 percent will be the prevalence of this disease in all human race, and 77% of them are from the developing countries. So that is the magnitude of problem, and that is why this is important to understand. Prevalence of diabetes in India, US, and Africa, they have projected WHO slide. Again, I have taken it. What you note that it is increasing exponentially. The diagnosis is increasing exponentially, and that is why we have to identify and treat the disease. What is the public health problem in Southeast Asia? More than 80 million people are expected to have the disease. And in urban population, 6 to 12% people is expected to have. So what is there? In urban population, it is far higher prevalence. And in Southeast Asia, particularly from India, Indonesia, and Bangladesh, most of the cases are clustered. And that is why it is important to identify them and treat them adequately. Coming to the natural history, underlying cause is the insulin deficiency. And what is the deficiency? In either the quantitative or qualitative. In type 1 diabetes, what is there? There is absolute insulin deficiency. In type 2, there is the partial insulin deficiency. There is lot of, some insulin is there, but the body requirement is not met by the available insulin. And that is how hyperglycemia occurs. What are the etiological processes? The etiological processes involve pancreatic disorder, chronic pancreatitis, or pancreatic resection, pancreatic infiltration, the pancreatic dysgenesis. So these all cause the hyperglycemia due to insulin decreased production. While destruction of the beta cell by autoimmune process, which is the most common cause of the beta cell destruction in type 1 diabetes. So what is there? There is the these cells are destroyed, and they cause less insulin secretion and hyperglycemia. There are other type of diabetes also in which the pancreatic cells are okay, beta cells are all right, but the insulin formation is there, but insulin molecules are not packed, and then they are not secreted, and that causes also diabetes. There is decreased insulin sensitivity, particularly resistance, which is there, particularly in the obese individual having lot of fat mass. There are genetic defects associated with the diabetes, particularly the Pickwickian syndrome, Wolfram syndrome. There are 8-9 syndromes defined, mostly in Caucasian race, and they cause the diabetes problem. There is autoimmunity. The patients develops autoimmunity against the beta cells, and they gradually destroy the beta cell. There are host factors, which is very, very important to understand. The prevalence of diabetes increases as the person ages, and that is why in younger population there is less prevalence of the disease, while in older it increases. And again, males are far more affected than females, particularly in the developing countries. While in the developed country, there is no gender difference noted. There is lot many studies which has done, and they talk about the hereditary concordance. It is far more common with type 2 diabetes than type 1 diabetes. There are genetic marker HLA-DR3 and DR4, and there is clustering of diabetes in the family, and they are can be diagnosed much earlier. The human factor, particularly cell-mediated and humoral activity against the islet cell. It is also postulated that in this pandemic of COVID, what has happened, people have developed the destruction of antibodies against the islet cell. And it is also known beyond doubt that even the COVID virus infection is diabetogenic. Obesity, decreased number of receptors for the insulin, and then after increased insulin resistance, both cause the increased sugar and the associated metabolic complications. Environmental factors, particularly sedentary lifestyle, more common in the people having sedentary lifestyle. People who have got malnourished and alcohol, they are more prone to have diabetes. Viral infection, particularly coccidiosis, rubella, Epstein-Barr, have been inclinated that they have caused insulitis, and they cause the long-term problem. There are drugs, particularly which are used in the cancer therapy. They also known to cause beta cell destruction, and they can cause that. Stress as such can precipitate diabetes in the susceptible individuals, and so is trauma. How they do it? There are multiple mechanisms, whether it is the insulin resistance is increased, or whether the inflammatory process has caused the more insulin resistance, or decrease the insulin activity, or there is also association noted with the cortisol. Increased cortisol is poured by the body, which is again diabetes. So the stress as such, major surgery, trauma can precipitate diabetes. Social factor, particularly affluence and higher education status, are more associated with diabetes. Classification, diagnostic criteria has been changed a number of times. What has actually happened? The largest study, UKPDS, as the analysis kept coming in, what they have noted that the hyperglycemic targets were gradually lowered. Initially, they thought that this much will be the target above which the diabetes be defined. But gradually, as the data started coming in, the people understood the lowering of the targets. And with the lowering of the target, what has happened? More and more people are diagnosed diabetic, and they are treated accordingly. And that is why it is important to identify these people and treat them. Previously used insulin-dependent diabetes mellitus and non-insulin dependent diabetes mellitus are now obsolete. Nobody uses them, but some of the older books do have it. WHO classification, which is the current one and very, very important one. It is in your books, and particularly Kumar Clark, which is they are mentioning, and what they are talking about in type 1 diabetes, there is the beta cell destruction, insulin deficiency, and there is the ketosis. So this is the triad which is there in the beta cell destruction, insulin deficiency. And again, it has got the two types. One is that the proven autoimmunity, which are the test GAD65, and if it is present, it tells you that it is the autoimmune destruction of beta cells, and that has caused the diabetes. In type 1b, there is no demonstration of autoimmunity, but there is proven evidence of decreased insulin, an insulinopenic state with no clear autoimmunity. In type 2 diabetes, there is variable degree of insulin resistance and deficiency. What it is not more common is ketosis is less commoner than in type 1 diabetes. There are other specific type of diabetes I will show you, and that is the genetic related beta cells function impaired, more maturity onset diabetes of youth, genetic defect, particularly insulin resistance lipodystrophy, pancreatic diseases such as cystic fibrosis, chronic pancreatitis, hemochromatosis, thalassemia, alpha-1 antitrypsin deficiency, congenital absence of islet or pancreas. These all are associated secondary to the pancreatic disorder. Secondary to other endocrinopathies, particularly the Cushing, acromegaly, they are known to precipitate diabetes. So these are the ways we have to think on it. Other specific type, particularly glucocorticoids, you all know what has happened there in this pandemic. Lot of many patients have been taking the glucocorticoids, and they have been declared diabetics, as they know. Thiazide, again, innocuous drug, but in long term, it is known to cause the insulitis and also the diabetes. Asparaginase is used in the cancer chemotherapy. There are also association for the congenital rubella, the polyglandular syndrome such as the Stiffman syndrome, Epexed syndrome. These are the causes. Rare genetic disorders such as the Down syndrome, Klinefelter syndrome, Prader-Willi syndrome, Wolfram's myotonic dystrophy. So there are lot many genetic defects which are there. And again, there is the gestational diabetes. I will be taking separately this gestational diabetes because it is asked many times in your system as well as in the system. The first diabetes is defined as the insulin deficient due to autoimmune destruction. You will find in type 1A autoimmunity, presence of auto antibodies. In 1B, you find absence of auto antibodies. So mostly type 1 diabetes, when you find the insulinopemic state, also you find ketosis prone, young age, complications, and then after you find no auto antibodies or autoimmune antibodies, it's helps you in classifying the disease, and because the therapy is different for this. In type 2, there is the combination of insulin resistance, insulin deficiency, residual insulin to prevent glycolysis and ketosis. The requirement of insulin for optimal glycemic control and for non-obese individual islet cell antibodies. So these are the ones which are known to cause the type 2 diabetes. And that is why it is important. In type 2 diabetes, there is huge scope of the oral hypoglycemic agent. And these can help to prevent complication in long run. Maturity onset diabetes in young age, this is a subtype of diabetes in which the autosomal dominant inheritance takes place. Autosomal means that familial clustering you will find. And early onset hyperglycemia and decreased insulin secretion. So these are the ones which are in that. What is important that it is suspected in with the people if there is the last 3 consecutive generations, it is not. And what is the long-term complication? Retinopathy, neuropathy, and treatment is again the weight reduction, oral hypoglycemic agents, and insulin. These all are useful. Gestational diabetes, again diagnosed first time in pregnancy. Mostly it is found at the 4th to 6th week, but many times you will find the pre-diabetics are diagnosed on pregnancy. These are not caused the GDM, because gestational diabetes usually appears in 4 to 6 weeks or even later. So what is there? If the person is diabetic and then after he goes for pregnancy, what can happen? That these patients will have the chronic hyperglycemia, which will be dangerous to the fetus in long term. And particularly what is important in this, there is the inherent predisposition to either types of diabetes. Because if the GTM is known, there are strong chances, a 35% of the risk, increased risk of having diabetes. And hypoglycemia, which is there in GTM, mostly cures after the child is born, but many of them may not get cured and they continue to be diabetes. And there is associated role of perinatal mortality and neonatal mortality. And that is why it is very important to identify these cases right at the onset. 30 to 60% of women with GTM have got permanent diabetes in later life. And what they tell that more than 2 decades, most of them will be diabetic. So that is the role of understanding. So in gestational diabetes, there are three things happening. First thing, you suddenly find in a pregnant lady hyperglycemia. If you know that she is hyperglycemia, you may find in the early part of pregnancy. She comes to for the follow-up just after missing her date, and you find she is hyperglycemia. So you cannot say it is gestational. It is the pre-existing diabetes which you are detecting during pregnancy. But gestational diabetes is mostly in 4 to 6 weeks or even later. They are the ones, but what they do in normal practice, suddenly they do sugar and then they tell that it is gestational. Because gestational is milder disease compared to the hyperglycemia due to diabetes, which was pre-gestational. So that is why it is important to identify. But we have to counsel whoever has got the gestational diabetes that they will have the permanent diabetes in later life. And that is why adequate caution and treatment plan must be explained to these patients. So how to diagnose the clinical feature and laboratory distinction? What are the clinical features? Clinical feature varies. Type 1, what you find? Thin-built people, ketosis prone people with polyphagia, polydipsia, polyuria, and then loss of weight. But while in obesity related, particularly in type 2 diabetes, they will find asymptomatic. And they have come for something, medical examination for recruitment, medical examination for change of job, or medical examination for the any reason. And then you find that they are there, you will call diabetics. And laboratory investigation, there are clear guidelines, which I will come to that, how to diagnose them. So first and foremost thing, don't only jump to the laboratory. Think the clinically also. The clinical index will make your diagnostic accuracy far higher than the vice versa. So that is why you ask the clinical question, is there polyphagia, polydipsia, polyuria with loss of weight? May happen that these cases have to be investigated before they started. But index of suspicion is the only way through which we can diagnose it in time. Laboratory investigations, I will give you the cutoffs, how to go about that. So, what is the type 1? Polydipsia, when the patient feels thirsty very often. Polyuria, nocturia, and rapid weight loss. Maybe the only one of these symptoms. It need not be that all six symptoms will be there. So when you find any of them, you should test the person for diabetes. And often what can happen, if you are less careful, you will miss the history point, and then you miss the diagnosis, and it causes morbidity. And what is important? It is not important that the suggested clinical picture will be there in each and every patient. So that is why we have to have flexibility, and we have to. Particularly in diabetes, type 1 diabetes, many of these children reach the hospital when they have got diabetic ketoacidosis, which is an acute complication of diabetes. In type 2 diabetes, they are mostly asymptomatic. There is element of chronic fatigue, malaise, and increased susceptibility of infection. These are the ones in which the more infection occurs. There is obesity, there is hypertension. You can see there are 70% more chances, 50% more chances. So there is not the one disease, but there is the host of disease. So that is why whenever obese person comes, the sugar, fasting, and other tests should be done so that we should not miss out. They may present with complications, particularly paresthesia due to the nerve involvement. And nerve involvement, how it occurs, I will tell you in the complication. But it can happen in the mononeuritis multiplex. It can also occur in the cases, particularly the post-operative, post-COVID. So these are the ones which are newer ones. And with what are the complications? There is paresthesia, ulcer foot, weakness of the leg, diminished vision, increased macrovascular configuration, macrovascular complication, dermopathy, necrobiosis lipidioca, diabetic fulcrum, diabetic fulcrum. So these all can happen in type 2 diabetes. How to investigate? To investigate, you have to do with the urine analysis. It is the simplest one to do. Anybody can do. There are restricted tests available, and they give the answer in the band form, 1 plus, 2 plus, 3 plus, 4 plus, and like that. The urine analysis by strip is not a reliable sign. The reliable sign is measuring sugar, fasting and PP, measuring the HbA1c, measuring the oral glucose tolerance test, and then after immunological markers such as GAT65, so that if there is the individual is suffering from autoimmunity, which he or he has acquired at the birth. So these are the ways we have to do. The urine analysis, whenever you send, if it is more than 250, the first and foremost test is the routine microscopy, and then after you will find that the cast, you can find the bacteria, you can find the other parts of yeast cells, but glucose and ketone must be done, because glucose will give you the degree of hyperglycemia, but it does not correlate to with the glucose and serum glucose and urine. But ketone bodies, if it is there, it definitely suggests that there is the hyperglycemia, and particularly the diabetes. And these are the ways you have to do it. The urine, what you find, glycosuria, if you find, why it occurs in urine, because when the renal threshold, what has happened? Urine has got the property, that kidney system has got the property to absorb the available extra carbohydrate. Sugars. So what will happen if the sugars is less than that? They will scavenge all the sugar and keep it inside the body. When it is increasing, what will happen? These sugars come into the urine, and that is present. Then there is the pregnancy. Pregnancy is the diabetogenic state. Many of the uh, governments have identified it in India, but we have to understand if it is the renal threshold is increased, say 180 is the renal threshold of the um, blood sugar. If it increases, then it comes to urine. Pregnancy, again, the causes are there. Pregnancy causes the insulinemic state. It also causes increased inflammation, and it may cause the glycosuria. And that is why we have to think of that. Elementary glycosuria can occur if somebody takes lots of food which is rich in carbohydrates, particularly the junk food. Ketonuria plus individual on fasting, stress exercise, persistent vomiting on right fat, and low capacity. What is happening in ketone? Why ketone occurs? The sugars are there. They should be metabolized to carbon dioxide, water, and energy. What is happening? When they have got the fasting or tremendous stress, food is not given to him. What does the body does? They make use of the available sugar, and they show it that. But when the sugar is increasing, but sugar is not going inside the cells, what will happen? They keep rising in that. And then by anaerobic process, they break into acetoacetate, which becomes a ketone in your urine. And then they present with the ketonuria, which is a life-saving disease. And we must learn how to treat these cases. Okay. Lab investigation, fasting glucose should normally less than 100 and random less than 140. The disadvantage is that if fasting glucose very time, it is inconvenient, and abnormal value, if one is there is the oral glucose tolerance test should be offered. This is very important slide, and this is the diagnostic criteria, WHO criteria. You must understand, and it is the simplest way to explain you where your patient is. Normal adult fasting less than 110 and postprandial less than 140 is normal. But what can happen? They can have the increased sugars, and then we have to take into cognizance of diabetes and treat accordingly. What is IGT? The IGT is a glucose tolerance test. So what they're doing in fasting, they are keeping person fasting, and then after they give him something to eat, and after that what happens? The sugars increases and they can be identified. But one thing very clear, that is the WHO criteria. What is that? The fasting more than 126 and postprandial more than 200 is always considered as diabetes. While in random sugar of more than 200 and symptoms again makes the diagnosis of diabetes. Fasting glucose, if the more than 125 milligram deciliter, it is straight away taken as diabetes. And 2 hours postprandial, if more than 199 in OGT, again it is classified as diabetes. Gestational diabetes, there are all pregnancy with IGT and IgM. But one thing very important, European criteria is emphatic that fasting more than 99 milligram, more than 100 straight away, it takes to gestational diabetes workshop. And 2 hours after glucose, 162 gram per deciliter. So what is there? If either of the criteria is met, again, it is taken as diabetes. OGTT, it is very important question. It is asked in your exam. Unrestricted carbohydrate used for 3 days, and then after overnight fasting, and then you 30-minute rest before the test, no smoking, and 70 gram of anhydrous glucose in 300 milligram of water is mixed, and person completes in 1 hour. And after taking, she starts the testing, and then after you can test every half an hour and make a chart, and seeing the chart you can diagnose it. So what is the key aspect? The key aspects are three. First is 3 days of liberal and liberal diet for 3 days, unrestricted carbohydrate. Second is overnight fasting is important. That patient must fast overnight, and then after he should be comfort test. And after 3 minutes of test, before that he should rest for 30 minutes. There should be no smoking, and then you have to give the fasting sample you collect. 75 grams of anhydrous glucose you mix in 300 ml of water, and patient should gallop it in 10 to 15 minutes. It is not that he keeps sipping, then the result will be erroneous. Blood and urine for glucose tested, and every half an hour interval till 2 hours, and a chart is plotted which you can diagnose that. So you see what is happening here, that oral glucose tolerance test, the fasting one, that is most of them are below 200, and the moment the patient is given 75 grams of glucose, the glucose rises but not more than 200, and then after it start declining, and it can decline in the normal level. In the renal threshold, what can happen? That renal threshold can come, and then after person is glycosuric much before actual diabetes. And lastly, the diabetes, which are that after 30 minutes, the sugars are more than 200, and it remains more than 200 up to 2 hours. Then again, diabetes is defined. So I have explained you why, how to do it. 75, no smoking, waiting for 30 minutes, then after checking every half an hour till you see the finality of the result. Glycosylated hemoglobin, what is happening? It is important. There is lot many concepts about that. The hemoglobin variants are there. Low hemoglobin is there. Then they take lot of sugars to become percentage-wise higher. So there is normogram. But one thing very important, the normal glucocorticoids is around 6 to 8%. But when there is a diabetes, it is increasing. If it is more than 8%, definitely it is diabetes. But based on that, the treatment is usually done. And what we have to do, we don't go for the blanket one assessment, and better get it examined by the professional, and then you will be able to find the cause. Immunogenic marker, particularly in type 1 diabetes, GAD65 is known. Insulin associated antibodies, again it is known. So these are the two ones which are clinically available for the treatment diagnosis, and if they are present, then you can think of type 1 diabetes. You will not waste your resources such as oral hypoglycemic agent, because they may come with the complication. Very important aspect, particularly this is asked in your exam. In India also it is very many asked. Who are the people to be screened? Everybody more than 45, every 3 years must be screened. And in NCD, that non-communicable disease program, also they say that every 3 years must be done, and yearly also is mandated if there is a strong family history, or there is obesity, habitual physical inactivity, or known case of IGT. So these are the people who have to be careful about, and more focused treatment should be there. GDM again, if somebody is born with GDM and the baby is bigger, this is again an indication for GDM and they can be evaluated. Hypertension and dyslipidemia, if any of them is there, the cause may be the diabetes, and that is why all cases of diabetes and hypertension and dyslipidemia, we must do fasting sugar so that the diagnosis can be made. I have come to the end. The important aspect is that you have to have index of suspicion. What it is there, 12% of the urban population, they have the problem. While the rural population, it is less compared to urban. Second issue, which is important, is that the rise of the disease in as such. And then the gestational diabetes or the family history of pancreatitis or autoimmune disorder, particularly autoimmunity against the beta cell. These all are the bad incidents and they can cause diabetes. And how to diagnose? More than 126 at the fasting, more than 200 postprandial, and if there is a symptom, anytime sugar more than 200 to be taken as diabetes. The HbA1c, there are criteria, but universal large societies have come to more than 5.7 is pre-diabetes, 5.7 to 6.5 is the pre-diabetes, and more than 6.5 is the diabetes. So this is the HbA1c is not standardized across the board, but these sugars can be done at the bedside and you can diagnose it. So this is the thing I want to emphasize, and the concepts behind each of them I have tried to cover so that you are benefited. Hello. 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 You can share your feedbacks. We will definitely do that, and we will share you the answer. I will share my PPT with you on email. Thank you.